our first guest, Dr. Chris Chenard. Doing a little bit of Q&A with him, very informal. Just trying to ask you a little bit about your practice. We've had the pleasure of seeing his patients, and as a sports medicine orthopedic surgeon, that's our passion. So just trying to get to know him a little bit more, and we've got the squad, the team. So let's start it up. First of all, tell us a little bit about your practice, what you're up to these days.
So I practice here in Broward County. I also have one office in Boca, so Palm Beach in Broward County. And I do, my subspecialty in orthopedic surgery is sports medicine. So I do a lot of arthroscopy. I treat, hip, elbow, knee, and shoulder. And a big part of my practice is sports patients. It's also, the aging athlete as well. So I also do, patients partial knee replacement, hip replacement, shoulder replacement. So, and I do take trauma call in the area as well. So I get a fair amount of fractures. So I do a lot of different things. That's one of the things that really attracted me to sports medicine is you can, treat a lot of different parts of the body. As opposed to just focusing on, the hand or the foot. For me, I like to be able to, treat different parts of the body and diagnose and treat different problems. So, and I see patients in the office. Not everyone ends up having surgery. I work really closely with a lot of people, particularly in this office with a lot of my patients that particularly have really high demands for activity or sports. I have patients that come from, law enforcement, patients that come from military, athletes, kind of all levels from semi-professional to, recreational athletes. And, I really have enjoyed, sending my patients here. So, because you do have, in my opinion, the top tier facility in the area for actually getting patients back to real sports or real high demand activities. The facilities you have and the expertise level you guys have here has been, really outstanding for me to have this as a resource. So.
Appreciate it. Wow, that's humbling over here. You were telling me about a case a little bit a couple of months ago. It was nuts. It was super complicated. If you want to elaborate for these guys?
I mean, I think probably from a sports medicine's perspective, when I'm taking care of patients, in the trauma setting, that's usually some of the craziest injuries that I have. So I would say my motor sports patient population usually provides the most stumpers in terms of patient treatment. I mean, we were talking the other day, a couple months ago, I had a patient who was a motorcyclist. He had a knee dislocation with a large, laceration over his knee after a motorcycle accident. He actually had, a ACL, a Pcl, an MCL tear. The really unusual thing that had happened to him is that he had torn both, the meniscus is kind of like a disc-shaped structure that's a C, and it's attached to bone at 2 points, and the rest of it is attached to the knee capsule. And he had actually torn the attachment of his meniscus off of bone, and with that, he basically had his meniscus when he showed up in the emergency room was actually just completely hanging out of his knee. So it wasn't torn anywhere else except off of the bone, and it was outside of his body, which was something that, I later, did some breeding to see if anyone had ever seen anything like this before. It's definitely, to my knowledge, never happened before, but it was a really unusual injury. But, for him, we ended up doing, kind of a staged approach with those kinds of injuries, with the high energy traumas, and especially an open injury. I'm very concerned for infection. So I kind of pushed the meniscus back in the knee, cleaned him up. I eventually brought him back and, it was almost like a meniscal transplant of his own meniscus. So I had to, drill tunnels and put anchors and stitches all around to repair his meniscus and ultimately bring him back for, ligament reconstruction. But I'd say usually the most unusual injuries I have are the motorsports enthusiasts. So
yeah, that's crazy. Hannah is our clinical education coordinator, did a great post on ACL grafts about, a couple of weeks ago?
Last week.
Last week. Do you want to kind of elaborate on what you found in your research, and we can ask Dr. Chenard what he thinks.
Sure. So the research for patellar grafts and for hamstring grafts, I didn't find too much. As far as re-tear rate, from the research that I read, it was pretty comparable. The healing timeline for the bone fixation versus the soft tissue fixation was a big difference. The 6 weeks to the 8 to 12 weeks. So that might play a role in our rehab process. But what do you think for return to sport athletes? Do you like the patellar grafts better or the hamstring?
So I think for grafts, I think it really depends on region and type. So I think in the post that you did, the breakdown is there's autograft and allograft. So allograft is a tissue that you take from a donor. So it's not the patient's own tissue. It's been tested for diseases. It's treated, preserved. But I think a lot of the literature, especially in higher demand athletes, especially in young athletes, shows a higher failure rate for allograft tissue of any kind, whether it's with bone or without bone. In terms of the autograft tissue, which in my hands, treating patients, I will, in almost everyone, if I think they need an ACL, I'm going to do an autograft tissue, and I think it really depends on surgeon experience, right? So I think there are many surgeons who are very, very facile with doing hamstring grafts. They have excellent results. I think other surgeons are more comfortable with patellar tendon. I think in this country, in the United States, if you're a contact athlete, you're going to end up with a bone tendon bone graft, and that's just because that's sort of what's been done for most patients in the NFL and elite athletes, because the idea is that you can get earlier bone healing and potentially a stronger graft. I think the testing of the grafts shows that the initial time zero strength of grafts is actually higher for hamstring. But as the grafts incorporate over time, the graft structure changes. So when you put the graft in, it has no blood supply. It's tendon, it's not ligament. So as your body actually, heals to that graft and changes the structure of the graft, the strength properties of it change. So, I think, in my opinion, the hamstring grafts have initial stronger fixation. I think, over time, I think they tend to be actually a little bit looser. And I think that, for me, I'm more of a patellar tendon graft fan. I do a lot of patellar tendon autograft, and particularly in military, law enforcement, elite athletes, I think that the strength of fixation is better, and you get earlier bone-to-bone healing. The other grafts you didn't mention, but has kind of become more popular, which I talked about in the post a little bit, is quadriceps tendon graft, autograft.
I'm interested.
So I'm a big fan of the quadriceps tendon graft. It's been around for a long time. It's been the first time anyone ever published on it in research was in the late 70s. And then there's a really famous surgeon from Connecticut who's been doing quadriceps tendon grafts initially with bone, and later on just soft tissue. And he's been doing that since the 90s. And I think in the last I think about 10 years ago, they did a survey of all sports medicine surgeons in the United States, and about 1% of people were using quadriceps tendon grafts, which is very low. So it was not a popular graft at that time. I think in the last 5 to 6 years, there have been a lot of big studies of the outcomes of quadriceps tendon graft, soft tissue graft, so meaning not including a piece of bone, like the patellar tendon has bone on both sides. And the outcomes have been equivalent to, a patellar tendon graft in terms of strength and return to function, and in some ways better, because the loss of quadriceps isometric muscle strength and muscle bulk is actually a little bit lower with quadriceps. And in addition, there's almost no anterior knee pain associated with harvesting quadriceps grafts. I'm sure you've probably dealt with, many patients with patellar tendon grafts. Anterior knee pain, knee numbness, scarring, is a significant concern with patellar tendon grafts. And the quadriceps tendon graft can be harvested through an incision that's less than 2 centimeters wide, whereas the patellar tendon graft, as you know, usually has a much more significant incision. So I personally am a big fan of quadriceps. I've been using it as one of my primary graft choices for ACL reconstruction. There's no variability in graft size, so hamstrings, if you have a younger patient, you may not be able to harvest a big enough graft, whereas quadriceps tendon, there's almost unlimited size of graft. So I think over the next, looking to the future, in my opinion, I think the quadriceps tendon graft is the graft of the future. And why it hasn't been used in the past, some of it's technical and some of it's research related. So the research is there now, and a lot of the actual technical aspects of preparing a quadriceps graft have changed in the past 5 years, and a lot of people have adopted it because the graft preparation techniques, meaning how you actually prepare the graft with sutures, has become much easier with the invention of kind of some new technologies that allow you to use those grafts and prepare them quickly and easily.
That's awesome. That's great info, very thorough. You're in the OR pretty much all day. You were talking about your hectic schedule. I know Alex had a question.
Yeah, so all of us are actually curious to know, when you're in the OR, do you have a certain playlist that you like to rock out to
So
when you get into it?
For sure. I mean, I don't always listen to the same thing, and some of it has to do with the audience, you know, so it depends on who else is in the room because it's a team, right? So if I put on country music and nobody else wants to listen to country, then, you know, it's not going to be a good day. But usually nobody has any complaints when I really like listening to kind of some music that has a beat and is a little faster. So my favorite, one of my favorite artists is Lane 8. He has kind of a house music kind of vibe, but it's very, very kind of relaxing, but it's kind of got enough pace to it. It keeps me focused, and doesn't really have many words, so it's not going to be distracting to anyone in the room, and it just keeps everyone on task. Yeah.
That's what's up, man. Thank you.
We've been talking a lot about surgical procedures, but as far as preventative medicine, Jacqueline's done some extensive research in PRP and stem cells. So where are you finding we're finding success and application for that?
So with the research that I was involved in, they used PRP as well as stem cells for knee osteoarthritis, and ultimately they did have great outcomes long term. So we tested 6 weeks, 8 weeks, and 12 weeks, and from 6 and 8 weeks, there was no statistical significance, but at 12 weeks was when people started saying, like, getting much more pain relief, feeling much better, and more function. So I feel like ultimately everyone needs to just kind of hold on and be patient if they are receiving that kind of treatment, compared to getting, a steroid injection where they might have immediate relief.
Yeah.
Is that what you're seeing on your end?
I think it's complicated dealing with biologic therapies because on the one hand, and when I say biologic, I mean utilizing, live tissue or things that, you take from a patient. So PRP involves, for those that may not know, it involves isolating blood from a patient, removing some factors from it. So, the large cells, and you end up with platelets, which are kind of like bits of cells, and some of the growth factors in the serum of your blood. And stem cell therapy, which may not be the most accurate name for it, but it basically involves taking from bone some of the bone marrow elements, which do contain stem cells. And there's a lot of enthusiasm for biologic therapies because they have a lot of promise, right? Because that's where all the science is going, is trying to do regenerative medicine and to make things that are a solution that's not just metal and plastic, especially for patients that have arthritis. But the indications for who is going to have a successful treatment with PRP and stem cells, the expectations for patients are all over the map. So if for some people that treat these problems say if you look at everything, if all you have is a hammer, everything looks like a nail, right? So I think that you have to, in terms of choosing patients for using these therapies, it's difficult, right? Because I find that, with a knee osteoarthritis patient, there's a big difference from a patient that has, a focal chondral lesion, so an area of cartilage that's missing, but the rest of the knee is okay, versus someone who has, one compartment of the knee that's, arthritic of the 3 compartments and the rest are okay, versus someone who has complete, loss of cartilage, full-blown arthritis, bone spurs, complete joint space narrowing. And for me, the more arthritic the knee is, the less optimistic I am about long-term effects of biologic therapies. I think that the short-term effects of biologic therapies, and whether that means, a few months versus, a few weeks with steroids versus biologics, I think that it can be helpful for some patients, but I am reticent to, kind of sell these therapies to patients where I don't think that there will be a benefit, because they are very expensive, they're not covered by insurance, and they're often, in my opinion, in many cases, not proven by science yet. So I find that the recovery period for PRP stem cells, yes, can be longer for for arthritis, but I also don't think it's durable. The more severe the arthritis is, I don't think that it's been proven in my understanding of the literature anywhere that these therapies are actually regenerative, so meaning that they can reverse arthritis. There's nothing that we know of that can reverse arthritis. In my practice, one of the areas that I find that these biologic injections can be really helpful are in tendinopathies. So, doing a PRP injection for Achilles tendonitis, patellar tendonitis, lateral elbow, like tennis elbow tendonitis, I find that these biologic factors and sometimes just the trauma of actually getting them inside of the tendon can stimulate a healing response. So for me, I'm more of a fan of it for tendinopathies than I am for arthritis. But more focal chondral lesions, less advanced disease, I find that it can be helpful.
Yeah.
Do you recommend to your patients to take any other supplements like chondroitin or glucosamine?
I don't, and I think that is, I see it all the time and I get asked about it all the time in the office. I think, a lot of these, the supplement industry is very, unregulated. I think chondroitin and glucosamine, you'll find, some more so than many other things, you'll find research on them saying, some effect or no effect. I don't find that it's a particularly useful therapy, and it depends. It depends who's taking it, but I haven't found in my practice that it's something that people get a really good response to. I find that people always want to, find something that's helpful to them, that's not surgery, that's not injections, that's not therapy, that, is nutritional. But, I don't think I've found it to be too useful for me.
Mm-hmm. Yeah, absolutely. When someone does have to go into that, I know you do total joints as well. I think one of the main questions that we hear a lot is, hey, my knee keeps clicking by the kneecap,
Yeah.
What's the reason for that patella clicking?
So, there's no way to do a really minimally invasive knee replacement. I think that, in order to get inside of the knee, you have to make a big incision to actually replace the knee. So, what does that entail? It entails, removing the arthritic portions of the knee. It involves removing some of the synovium or the lining of the knee, which is oftentimes inflamed at the time of surgery. It involves actually cutting, some portion of the front part of the knee and to actually move the patella of the kneecap over. The vast majority of surgeons will remove a portion of the fat pad behind the kneecap to actually allow you to visualize the surfaces of the knee that you're placing the implants on. All of those types of things, will cause scar tissue. So, I find that patients that have had joint replacements will have, anterior knee clicking, up to about a year or more after surgery, and that's sometimes just scar tissue. So, removing those elements of the knee, your body is going to respond to that as an injury. It doesn't know that someone's doing something to the knee and they're trying to help you. The body thinks that they've had some kind of trauma to the knee. So it's going to form scar tissue. I find that diminishes over time. There are other things that can cause clicking in the knee after a knee arthroplasty. Sometimes scar tissue that if the undersurface of the patella or the cartilage surface is replaced, it would do a patella resurfacing with a knee replacement. Sometimes scar tissue can grow around that and cause a pinching as the knee goes into flexion. You can get a pinching or a snap there. This is it's called patellar clunk. I think that's been reduced with a lot of the new designs of implants. But for me, with knee arthroplasty, I try to limit the amount of trauma that I can to the knee. So I do partial knee replacements for some patients that have disease limited to one part of their knee. And I do what's called selective patella resurfacing. So many patients that have knee arthritis do not have arthritis of their patellofemoral joint or their joint of the kneecap. So if someone has a full healthy looking patella when I'm doing a knee replacement, usually I tell most of my patients if it's not obvious from their x-rays they need a patella resurfacing, I don't actually resurface the patella. So I leave the patella in place, I replace the femur and the tibia, and I find for me, I find that limits potential complications and potentially limits some scar tissue and decrease in function.
Nice, good info. We were saying before, you're a busy guy. I know Dustin had a question.
Yeah, definitely. So I know that you have busy days, we have busy days. One of the things that we do, and we all talk about it throughout the day, is like we watch a lot of Netflix, TV shows. So we were kind of curious to see like, what are your shows that you're kind of thriving on right now?
Oh man, so I actually talked to Carson a couple weeks ago, and he was talking about this show Yellowstone, which I've started watching, which I'm like still in the first season, so don't spoil anything for me. But I've gotten into that lately, and I definitely like some comedy shows as well because it lightens up the day. I've definitely watched. I recently watched the Ted Lasso show which was pretty funny, and I watched I Think You Should Leave on Netflix. I don't know if anyone's watched that, but
What's that?
it's like a sketch comedy show, but
Okay.
it's I don't know. I think it's
Add to the list.
it's one of those shows that's painfully awkward but funny.
Yeah,
So.
it's always good comedy when it's kind of awkward.
Schitt's Creek type?
Yeah.
What's that?
Is it Schitt's Creek type humor?
Like-
Oh, that's a great show too.
Yeah.
But I don't know if that show's so awkward. This show is real awkward.
Make you feel
Is
more
the
comfortable.
Would you say The Office is awkward or no?
Sometimes.
Yeah.
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 If you've never
Sometimes.
seen it,
Yeah.
Talking a lot about the knee. So one of the things that we never get a chance to see, or very rarely, is a lot of times we see patients coming out of ACL reconstruction. So, or their knee has kind of calmed down. So I feel like we don't get the opportunity to do a Lockman test
Sure.
for the ACL. So as much as you probably do seeing patients in the clinic. So we were hoping that you could show us using this table here, and Hannah is going to be the patient today. So let's go to the table here, and if you don't mind showing us
Sure.
on the left knee.
Yeah, so, for me, the knee examination, being able to actually examine, to get a valuable examination of the knee is largely being able to get your patient to relax. So that's probably the most challenging part to get a real exam. So a lot of times patients will come in with a knee injury, they'll lie on the table kind of like you are now, they'll sit up. They often will like to put their other knee up like this, which kind of tenses their muscles in the body. So the first thing is actually positioning the patient is getting, so I would say, would you please lie down? If the other knee is bent, then I ask the patient to actually, put the other knee down. And so many people will have, guarding of their knee, especially if they've recently had an injury. So depending on how much you're able to get someone able to relax, some people are very, very relaxed people, and it's very easy to actually get an examination of them. So, if you're going to perform a Lockman examination, I'm turning my back to the camera, I'm sorry here, but I like to be on the same side as the knee that I'm examining. And I put my upper hand kind of on the thigh here, and that allows me to squeeze the femur and actually hold it and stabilize it. But it also allows me underneath to feel the tension in the hamstrings here. So we have a very relaxed person right here, so that's not a problem. But if I were to feel in the back, if I could feel that I have a tight hamstrings, if now she's tensing her biceps femoris, I can feel it now, then one of the things you can do is actually just bring the knee to the side like this, and that actually allows you to feel in the back that the cords of the hamstrings are relaxed. Because what's going to happen is if you have a patient that's tensing up, if you're feeling that the biceps femoris and the rest of the hamstrings muscles, you're feeling cords in the back of the leg, you're going to have a very difficult time examining their ACL stability. And then performing a Lockman, basically you just, for me, I have my upper hand on the upper thigh here. And you want to I put it into a reduced position first, meaning that the anterior cruciate ligament is creating, stability to anterior translation, right? So if you are holding the knee up like this, and you're holding up the calf like this, and you're pulling the leg, forward, the tibia forward, or even the force of gravity, you may not sense when you actually pull forward that you're actually translating it all, right? Because you may have already translated the knee anteriorly, so the tibia anteriorly versus the femur. So what I do is I bring the leg to the side, I'm stabilizing the upper thigh with my hand, and I put my thumb on the tibial tubercle, and I kind of make sure that the knee is pushed posteriorly. And then as it's pushed posteriorly, I feel that, and you can, Hannah probably feels that, but basically there's end point that you feel there. So as I'm bringing the tibia forward, I'm stabilizing the knee here, relaxing the hamstrings here, I push back, and that's a very tight ACL there, you know, because as I bring the knee forward, I feel for an end point. So I push back, and I pull forward, and you feel basically as that, you know, ACL elongates to that position, you should feel some pullback from the knee. One of the most valuable kind of examinations for patients is not the Lockman only, is the pivot shift examination. So I don't know if you guys ever had a chance to see a patient with a pivot shift, but the pivot shift relies on the function of the iliotibial band, and basically the function of the ACL is it's not just a translational, meaning anterior translation of the tibia, but it's also rotation. It controls rotation because your ACL runs in this direction. So it actually stabilizes the knee in rotation, which is why patients that have ACL injuries, it's vast majority of the time from a twisting injury. So that it's actually a twisting, a rotational component to the injury. And doing a pivot shift examination involves basically using the ACL's kind of unwinding effect and seeing, you know, when that's lost in the ACL, you can actually sense it. So that basically Gerdy's tubercle is this bony prominence that's right on the front of the tibia here. And that's where the iliotibial band actually connects. And so when you're doing a pivot shift examination, if you rotate the tibia forward in the lack of an ACL, the Gerdy's tubercle is going to end up in the front of the knee here. And you push a little bit of valgus and flex the knee up. And what you'll feel is basically as the iliotibial band crosses the center of rotation of the knee, it will reduce this part of the tibia backwards. So it comes forward like this, and then as you start to flex the knee, it will pull the tibia backwards and you'll feel a clunk. So that's, you know, I think that's a good examination. It's very difficult to perform in an acute injury, but actually doing a pivot shift examination, which of course yours does not, you'll feel, I put my thumb on the tibial tubercle, I rotate the leg inward, I give a little push to valgus of the knee, and I bring the leg up like this. And you can feel that tension there. And then in the presence of an ACL injury, the tibia will actually fall and rotate externally, because what happens is the iliotibial band becomes a flexor of the knee and it will pull the tibia back. So those are the two main, you know, examinations for an anterior cruciate ligament injury. And of course, if you're looking at a knee, you have to look at all the ligaments, right? So you may get a false Lockman if you have a Pcl injury. So, you know, the Pcl test, you know, usually I sit on somebody's foot like this. I put my thumbs on the femoral condyles. I put the meat of my thumbs against the tibia here, and I just give a push back there. And I feel kind of the step off between the tibia and the femur. If the anterior tibial plateaus actually make it flush with the condyles, that's about a grade 2 posterior cruciate ligament injury. If the tibia actually falls back behind the femoral condyles, it's grade 3, and that usually tells me that there's more than just the PCL injury, or it could be an ACL and a PCL injury. So, you know, when you're examining the anterior cruciate ligament, you need to do an examination both of the ACL and the PCL, because you may be sensing translation of the knee with your Lockman, but it might be from the PCL. So you have to make sure that the laxity that you're seeing, because as you guys probably see all the time, posterior cruciate ligament injuries in isolation are very successfully treated with quadriceps strengthening and physical therapy. Even when in elite level athletes, you can have a very high grade PCL and have them back in 6 weeks if they're really, really, you know, motivated. And that's it.
That's very thorough, yeah.
Thank you.
I know your practice is growing too with hip scopes, doing hip labor repairs. Is there a couple tests that you recommend? You wouldn't mind doing it on
Yeah, sure.
Maybe on the left side, that way we get the camera on the
Sure. So for hips, you know, there's the hip physical exam is pretty complicated, but you know, I think if you had one test that you wanted to test for, it would be for hip labral pathology, and that's this anterior labral pathology, is the Flexion, adduction, internal rotation test. That test is going to basically imagine the way that the femur is in the socket. So if your femur is a ball in the socket, if you flex the hip up, internally rotate, and adduct, it's going to bring into contact the anterior part of the femoral head into contact with the anterior part of the acetabulum. This is going to be very painful for people with arthritis, but it's also specifically painful in people with hip labral tears, because hip labral tears is, it's a area of sports medicine that's kind of come more to the forefront in the past 20 to 30 years. So it's not, people with groin pain in the past were oftentimes, told, kind of just walk it off, and we don't really know what's wrong with you. You might need a hip replacement someday. Your x-rays look fine now. Nowadays, when we understand hip a little bit more, that in athletes, it's usually caused by a bony malformation. So a traumatic hip labral tear, meaning a tear of the labrum of the hip, and a hip that has completely normal bone shape, is pretty uncommon. It can happen. But usually it's caused by some amount of bony malformation of either the socket or the femur, or more often it's a combined pattern where there's some element coming from the femur and some element coming from the socket. So what ends up happening is, instead of having a completely spherical ball inside of the socket, you have a roof that's too large, which is called a pincer lesion. So you can have in the socket some extra bone on the front part of the hip that's hanging down. It's called cranial retroversion, which means that instead of the top, the very cranial meaning top, so the top of the roof is actually twisted back a little bit. So when the hip comes into flexion, that part in the front is actually overhanging and coming into contact with the femur. And of course, the labrum is the tissue that surrounds that outer circumference of the hip. So as that extra bone comes into contact with the femur, it pinches the labrum. When the labrum tears, it actually starts to peel the cartilage off of the edge of the acetabulum. So it's an early cause of degeneration of cartilage. And similarly for the femur, you can have what's called a cam lesion, which is an increase in the size of the bone in a focal area in the anterior superior femoral head. And as that comes into contact, it will also pinch the labrum against the acetabulum. And that's because the femoral head is no longer spherical. So as you're trying to fit into a spherical socket, a ball that's not spherical, that bump is actually going to pinch up against the labrum.
So you've been in practice for how many years now?
Well, I graduated medical school 8 years ago. I've been in practice in Florida for 14 months. So before that, I was in New York for my surgical training. I spent a year in fellowship, and I was working with the New York Jets and the Islanders doing a sports medicine fellowship. So I've been around this and thinking about this for I guess nearly a decade now, and certainly was thinking about doing orthopedics long before that.
Sure. So with all the experience that you've gained and like all of the mentorship and all that stuff that you've learned, like where do you see orthopedics, even from just a general to a sports aspect, in the next 5 years? Where do you see orthopedics, orthopedic surgery and stuff? Where do you see it heading?
Well, I think that's one of the exciting things about, I'm sure that, we share about, our careers, is that you have to be, as a physical therapist, as a physician, a surgeon, you have to be a lifelong learner. You have to be, continually reading, going to conferences, and updating your knowledge. And it's often said, if you talk to older, physicians or surgeons, they say, 5% of what I do now is what I did during my training. So things change a lot, and they change rapidly. I mean, we talked about this before, which is during my training, for example, I think I probably saw a handful of quadriceps tendon ACL reconstructions, and now it's the majority, at least, I would say the majority, or at least 50% of the ACL reconstructions I'm doing are using quadriceps tendon. So you have to be flexible, and certainly that's not that big of a change of graft type, but you have to be flexible, you have to be a lifelong learner and willing to adapt and change to be able to give the best treatments for patients. And I think, where do I see orthopedics going? I see more biologic therapies, you know, from what we've been seeing, you know, especially in sports medicine, I think is at the forefront of that is regenerative, you know, medicine therapies, whether it be, you know, cartilage restoration surgeries, you know, and a lot of the older techniques have actually found a new place in orthopedics. So some of the realignment surgeries or osteotomies that maybe you're going to see patients, I'm sure you've seen plenty of patients that have, you know, tibial tubercle osteotomies or high tibial osteotomies. These were kind of old treatments that for, you know, problems that didn't have very good solutions in the past that have found kind of a new home in the era of cartilage and biology surgeries, where we're actually able to realign, you know, positions of the bones in the knee to actually offload areas of damaged cartilage in the knee and actually regenerate that cartilage or replace that cartilage with donor tissue or, you know, things grown back from people's own tissue. So the shorter answer of that is that, you know, I think the future of orthopedics is science combined with, you know, the fundamentals of orthopedics. So, you know, some of the, you know, I think it's really important, whatever you do, to know the history of your field and kind of why people do things the way that they do them now, because, you know, some of the old things come back in new ways. So I think, you know, the fundamentals of orthopedics, I think, are going to remain the same, and I think the science and particularly the biological aspects of treatment. So, you know, we've made a lot of progress in hip and knee arthroplasty, for example, and every year there's new implants for knee and shoulder arthritis that I see, but the outcomes are not so much different than they were, you know, 20 years ago for arthroplasty procedures for joint replacement. So, you know, in terms of the future, I think, you know, it's going to be less metal and plastic, and I think it's going to be more biologic therapies, so more cell-based therapies, and, you know, things like PRP and stem cells, I think, are just the tip of the iceberg. I think it's a good thought, and I may have sounded like I wasn't too enthused about it earlier, but I am enthused about the potential for where that's going, because I think those are the therapies that are going to ultimately provide breakthroughs for regenerative or restorative medicine that doesn't involve necessarily metal or plastic implants.
Kind of a follow-up to that, like, so I'm sure you have a good idea of like what we do as PTs, but if what you think is we're going more in a biological route, how do you think that affects what we do in terms of recovery, especially when it comes to like orthopedic surgeries, as far as like post-op protocols being more conservative? Do you think that maybe is going to potentially like speed that up for recovery and make our rehab and facilitation a little bit easier and recovery faster? Like, it may and it may not. You know, I think it completely depends on where things go with that. I think that on your end with physical therapy, I've seen things that I'm really excited about that you guys are doing. You know, Carson knows that I actually, you know, maybe 8 or 9 months ago, I actually had my biceps tendon repaired from a pickup basketball game that we were both playing in, and, you know, I had a very quick recovery from it, and I came in here for some of my treatment, and, you know, I'm very excited about some of the stuff that you guys are doing. I mean, we did some blood flow restriction therapy, which is you know, doing strengthening at low weight with a tourniquet on the arm, which allowed me to do some intensive exercise without actually stressing the repair. So I don't think everything's necessarily going to come from the arena of even where the surgeon is operating or the injections that are done. I mean, I think there's the whole team is going places, and I would love to have more of my patients do that, especially for, you know, extensor mechanism injuries, patella tendon tears, quadriceps tendon tears, and even, you know, ACL reconstructions where surgeons are worried about disrupting the repair in the early phases. I mean, we need to be able to actually prevent atrophy and keep patients. I think the key to getting, you know, patients actually back to sport quicker, or to have less of a significant impact on their life from injury, is actually, you know, having an innovative approach to actually rehabilitating these injuries, because it's not just going to come from the surgical table. So
No, it's exciting to work with a surgeon who has that mentality as well.
Thanks.
For us, it's sometimes we're baffled when we get an ACL who's 6-week post-op and they haven't done anything, because they were instructed by the surgeon, it's such a fragile repair, don't do anything, just do quad sets and ice type thing. So we definitely take a more accelerated approach and evidence-based as well.
I have one patient I'm thinking of in particular that had a patellar tendon rupture that was a mid-substance patellar tendon rupture, which is something that I know you
rehab,
I know you were taking care of him, and I sent him here specifically because I wanted him to have an advanced I was amazed at how quickly he was able to recover. I augmented his repair with a graft, but I mean he came in he refused to wear his brace and came into the office and it was almost as if he really was like, oh yeah, it's fine, like nothing happened to me, when he had a very significant injury. But I did send him to you guys because I knew that you were going to be aggressive with actually his therapy, and I designed his surgical reconstruction with that in mind, which is that I wanted something that would be able to stand up to early range of motion, early strengthening, because I've also had a patellar tendon tear myself. So this was when I was in medical school, I was playing flag football and I tore my patellar tendon, and the amount of atrophy I had after that injury, it's just so difficult to deal with. That these are the kinds of things where a strong collaboration between a surgeon and physical therapist can kind of overcome some of the big challenges of recovery, which in my mind is dealing with the atrophy, dealing with the physiologic changes that have to go with a body that doesn't understand that the trauma that it just went through was designed to help it. So it's so important to get early strengthening, early range of motion, a motivated patient, and that takes a whole team of people to do that. So I think, where is the future of orthopedics? I think it's more integration as well. Is actually and understanding on your end what I do, and on my end what you guys do, and I think there's a lot of opportunities for growth in terms of actually integrating that into one united front in terms of actually motivating patients. There's psychological aspects to it, designing the correct protocols that are as aggressive as possible, and in terms of getting patients back and having kind of people have buy-in and believe in what they're doing.
Absolutely, yeah. You're talking about a team and collaborative approach. Alex is our 6th PT coming down from New York, so you're mentioning some training there.
Yeah.
So we're trying to show them the ropes down in Fort Lauderdale.
Yeah, so you have 17 more months down here than myself.
Yeah.
Both coming from New York. So I was interested to ask if you have any recommendations about restaurants or even just places you like to lounge and cool off when you're not in the OR room out here.
Well, yeah, I mean, I think Florida's a great place to live. I've been super happy here moving from New York City, which I also love New York City as well. But it's a great place to have a balanced lifestyle. I'm able to play sports all year round. We play basketball, we play tennis. I've been really playing a ton of pickleball lately. I don't know if anyone else is interested in playing, but some of my patients that turned me on to it, and now I play. But in terms of going out, I mean, I think Fort Lauderdale is amazing, but probably my favorite place to eat in South Florida is Papa's Raw Bar. Has anyone ever been to Papa's? No?
What kind of food?
It's seafood. But it's really good. They have sushi. They have stir fry. They've got raw bar. It's right on US 1. It's in the Pompano area. So it's a little bit north of here. But that's my favorite restaurant. They make their own rum down in Key West, and it's
Papa's Pilar?
What's that? Yeah.
Pilar Pop, what's it called?
Papa's Pilar, yeah.
Pilar.
Yeah, and they have live music, live reggae every night, and it's close to one of the hospitals I work at, and I eat this po' boy sandwich there at least twice a month. So that's probably my favorite place to eat.
We'll have to go.
Yeah.
Sure.
We'll have to get Dustin plays ball. So is Alex and myself, so we'll have to get a SoFLo versus orthopedic team. I know you got your reps out there too, who can hoop as well. So
yeah.
Well, thank you very much. This has been super informative. It's cool to chop it up too, and kind of talk about some cases and really get some hands-on feedback as well and some experience as well. So definitely got to do this again. So thanks again.
I appreciate you guys for having me.
It
It's
was
really,
definitely
really awesome.
awesome.
Yeah.